Welcome to another episode of the Harley Street Health podcast. Today we're joined again by Dr. Ram, who's a Senior Vascular Surgeon over at Gleneagles Hospital. And we're going to talk about varicose veins today. I'll be honest with you, I don't know a huge amount about varicose veins, so Ram's going to enlighten me and yourselves. So, hello Ram, how are you?
I'm very well. How are you, Mike?
Yeah, great. So thanks for joining us again today. And I think we'll talk about varicose veins. We'll keep it to about 15 minutes. And I think maybe just start off with kind of how common are varicose veins and why are they an issue?
Well, actually, varicose veins are sadly too common. The sad truth is that we were never designed to stand. You know, we were designed to live our life on all fours. So we ended up creating this blood column from the heart to the ankle. And so the longer you stand, which means the older you get, the more varicose veins you're going to get because the veins will give way to the pressure. And varicose veins are just dilated veins in the leg that are trying to keep hold of all the blood that can't go back. And they appear as these ropey veins in the leg that can be, on the one end of the spectrum, a bit of a cosmetic problem. And on the other end of the spectrum can lead to serious complications with clots forming in the leg and ulcers forming in the leg. And it might surprise you to know that varicose veins are actually, or venous disease is actually commoner than heart disease, stroke, and peripheral arterial disease put together. And you would expect about 30 or 40% of a population to have it. In fact, if you take the average age of a population above the age of 18, so suppose the average age of a population is about 60 in a country, then you would expect about 60% of people to have venous disease. If it's about 40, you would expect about 40%, which is why Germany, being the oldest population in Europe, has the highest rate of varicose veins in Europe.
Okay, so it's really common, but how many people does it actually cause kind of problems? Like if you, not just cosmetic, but what kind of problems does it cause in a kind of non-cosmetic way?
And that really has been the issue, that for too long varicose veins have been looked upon cosmetically, when the truth is that most patients will have some degree of aches and pains, and that is really dependent on how much blood is pooling around in the leg. Remember, blood in the veins is low in oxygen, that's why it's going back to the heart. So essentially, you've got a percentage of blood sitting in your legs that is not as well oxygenated as it should be. So aches and cramps, shorter distances of walking and exercise, and that then progresses with time into far more symptoms of being unable to walk long distances. Clots can develop both in the superficial veins under the skin as well as the deeper, larger veins because of this. And then the complications really begin once the clots develop. So they are not just cosmetic, they are a cause of a fair amount of morbidity around the world.
So when you say clots develop, I mean, are we talking about kind of, do these develop into deep vein thrombosis and can lead to pulmonary embolus, or is it just superficial thrombosis?
Exactly that, actually. The idea that just the superficial thrombosis does not have a risk of a pulmonary embolism is not true. The risk of pulmonary embolism is almost 2/3 in a superficial venous thrombus as it is in a deep venous thrombus. So the simple fact is that if blood is static in the veins, it tends to clot. And if it pools in the lower limb, it will clot both in the veins in which it has pooled as well as in the veins deeper inside. So the risk of pulmonary embolism is real, but we don't seem to sort of associate what we think are cosmetic varicose veins with a possible fatal pulmonary embolus sometime in the future. So superficial venous thrombosis, or SVT as we now call it, is given pretty much a similar risk grading to proximal deep venous thrombosis in vein disease now.
Okay, so if someone's got varicose veins and they're worried about them, how can they tell if they're going to potentially cause problems?
If your veins are symptomatic and you get a characteristic swelling around the ankles, And the swelling that occurs because your veins are under high pressure from pooling in the legs is that the swelling will be around the ankle. It will involve a part of the foot, but somehow the toes tend to get spared when it starts. That's a very typical picture of varicose veins that are slowly going wrong. You also then start developing these fine vein-like lines just below the ankle. It's a term called corona phlegmatitica. It has nothing to do with the virus, of course. But that is a sign that venous pressures are getting higher and higher, and the risk grading now changes once this corona develops around the ankle. And then you start getting pigmentation in the skin just above the ankle, on the inside of the ankle. And these are signs that, okay, we are beginning to miss the bus. It's time to get something done fairly quickly. But if veins have symptoms, then they really need to be dealt with because it's a question of time before they create trouble.
Right,
unless you stop spending, of course.
And what about, so what are the things that really trigger the risk of varicose veins in people? What's going to predispose people to developing them?
There's a huge genetic component. Because we have decided as a race to stand, we have developed valves. And these valves are there to keep the blood flowing in one direction towards the heart and stop the pressure from coming back towards the ankle. So if you look at Egyptian mummies from about 3,000 or 5,000 years ago, they had only about 3 or 5 valves between the ankle and the groin. Today we have between 16 and 23 valves. So every generation is putting on valves to try and compensate for what we have started doing. And of course, some valves are well developed, some of these valves are poorly developed, and there's a huge genetic influence on that. So you will find that if mums had varicose veins, dads had varicose veins, your risk of varicose veins is high.
Right.
The other thing that causes a risk of varicose veins is something that prevents the blood from returning easily. And the commonest thing, if you want to call it that, is a pregnancy. The presence of a baby in the pelvis seriously obstructs the return of blood, at least during the duration of the pregnancy, but it can leave people a little loose overall, and including their veins a little loose overall after the pregnancy as well. The hormones related to the pregnancy are also designed to relax the tissues, especially what are called the connecting tissues, so that the pelvis is able to accommodate the baby. But sadly, this also affects the walls of the veins. The veins get a bit more floppy as well because of the hormones that are secreted in pregnancy. So if you have multiple pregnancies, you end up being left a little floppier than before. And that includes the veins. The third important thing, of course, is you don't have to get pregnant in order to have a belly. So if you put on weight, you do pretty much the same thing as a pregnancy. So obesity, genetic influences, pregnancy, jobs that require you to stand for a very long time, teachers and nurses, these are people who are at high risk of getting varicose veins.
Is it more common in women than it is in men?
It used to be thought that, understandably, because most men don't get pregnant. And so, women being pregnant tend to have a higher incidence. So yes, under the age of 40, women do have more varicose veins than men. But by the 60s or so, it's a 50-50 split between the two. Right. So men do catch up. I suspect men catch up because after their 40s, their belly begins to expand for different reasons. And so they tend to pretty much create the same risk factors as women with time.
Okay, so if I was a patient and I was coming to see you about to deal with my varicose veins, I mean, how would you treat them? What are the kind of conservative strategies that you can use, like stockings or medication? And what are the different surgical strategies that you might use?
Right. The first thing to do when someone comes in with varicose veins is to make sure what is the range of symptoms and how it affects their quality of life. So the presence of some varicose veins in someone who's not very mobile, and the presence of varicose veins in someone who normally would like to run 8 or 10K a day, their impact on their quality of life is quite different. So we do something called a veins quality of life score, which allows us to grade how bad it is. You can also do something called, and that should make you happy, Mike, it's called the Aberdeen Varicose Vein Questionnaire. Um, it was developed, sadly, in London, but has the name of Aberdeen going with
Where
it.
did the Aberdeen come from?
Well, it was joint research, I think. But it's called the Aberdeen AVVQ, or the Aberdeen Questionnaire, and that allows us to know what sort of impact it has on your daily life. The second thing we need to know is to really map which vein segments and which veins are not functioning well. So where are the valves not working well? Because the basic principle of all vein surgery has not really changed for 1,000 years, which is to shut the bad veins and push the blood into the good veins where the valves are working. This is the basic principle. In the old days, we used to shut the bad veins by physically taking them out of the circulation. It was called ligation and stripping of the varicose veins, a slightly brutal operation, although very rarely we have to still do it. Then we moved on to finding ways to close this vein with heat. So laser and radio frequency developed, and essentially that's like closing a plastic packet with heat, a popcorn packet with heat. So you pass a thin tube or a catheter into the vein that you're trying to treat, and you shut it with heat. Both laser and radio frequency produce heat. Laser produces a lot more heat, almost 600 to 1,000 degrees, while radio frequency does it at about 120. So although the results between the two procedures in terms of long-term outcomes are no different in all the trials have also shown that recovery from radio frequency is much better in the first 2 weeks or so. There's less pain and less bruising because the temperatures are less. However, there is a little problem with radio frequency, is that you need a bit of practice to do it. You should have done a few, and laser is a little easier to do. So the early starters tend to do laser more easily. Then we moved on to actually finding ways to stick these veins together. So now we use glue. There is vein glue, and chemically it's actually not very different from the super glue that you would use to stick your table or your pictures at home. Of course, it's been medicalized and all that, but it's in principle it is cyanoacrylate, which is the basic molecule in all glues. So we stick the vein together by putting glue inside it, or we can put a drug that causes the vein to scar up. So all these techniques are available, and of course the absolute new kid on the block, not quite available in Singapore, but should be available in Harley Street within the next month or two, is Sonovein, which is completely scarless ultrasound heat that is used to close the vein. So the principle remains the same: close the bad veins, shut the good veins, and try and do it with as few complications as possible.
So this Sono one, is that basically non-invasive?
It is completely non-invasive, in the sense that there is only here ultrasound, when it is will tend to cause them to close because they produce heat. Not everybody is suitable for it, and this is important to understand. That radio frequency and laser may work better on very large vein sizes.
Right. Okay.
Glue can be felt in people who are very thin and the veins are very close to the skin. They will be able to feel the glue, so you try and avoid it in them. Sonovein may not be suitable to everybody, where there is a nerve close by to the vein, and so on. So the idea that any one technique is a solution for all types of varicose veins is wrong. And any good unit or any good center should be able to offer at least one sort of heat ablation or thermal ablation technique like laser or radio frequency, at least one non-thermal ablation technique like sclerosant or the drug or glue, and at least one technique for veins that we call extra anatomical veins that are outside your normal vein territories, something like Sonovein. So you should be able to offer a range of procedures and have the skills to do all of them, rather than offer any one, because you paid for a machine and you're trying to use the machine again and again.
And what's the recovery like? I mean, are these people, if you came in for a vein operation, it was one of the invasive ones, would you be off work for a few days, a couple of weeks?
Well, you should go on the same day, even if you do both legs at the same time, and regardless of the size. yeah, they will go home the same day. And we expect patients to walk the same day. In fact, we encourage them to walk. And from the next morning, we encourage them to do at least a 30-minute walk every morning. And then it depends on their job as well. If they are in construction, supervising construction, standing on their feet all day long, we would recommend they take about 72 hours or so off work. On the other hand, if you are going to be, it's a desk job and you're looking at a computer, then you could probably go back the same evening, really. Although we have seen with the early results with Sonovein, where one of the surgeons had a Sonovein procedure. He had his procedure done in the morning, and in the afternoon he went back and did a couple of Sonoveins himself on other patients. So that's being bandied around. But yes, recovery from these is very quick. But the suggestion that there is absolutely no symptom and you will feel like nothing's ever been done to you after these procedures is not quite true. You will know that something's been done, and the leg does feel marginally uncomfortable for the first 2 or 3 days after any of the endothermal procedures. Okay. Although after glue, you will pretty much feel nothing.
And what is the what's the recurrence rate after these procedures?
And this is the strange thing. Regardless of the technique, the recurrence rate has remained fairly constant. Yes, and the quoted recurrence rate is between 5 and 15% at 5 years, regardless of what procedure you do for varicose veins. We had published about 5 years ago, when I say we, from my previous unit, that recurrence rate can be brought down to well under 5% if you map the veins properly before you start, because the cause of recurrence is usually a missed segment of bad vein in the original mapping. So I understand busy units, they only tend to look for certain points where the valves are not working. We tend to spend about 40-45 minutes scanning the patient, but that's for a very good reason. It's because we prefer to map all the veins before we start, because logically we need to know all the veins that are not working, but we also need to know all the veins that are working well, because that's where we're going to push the blood into. And if you don't have enough good veins, then you might get into trouble down the line.
So when you say mapping, that's with an ultrasound, is it? It's not an invasive?
It is, yeah, it's not invasive. It's a completely non-invasive. You don't need to starve. You pop in, and we take great pride in our vascular laboratory and how we do the scanning, because we take time, and we are a training laboratory for this. So we do take our time, but it is an ultrasound non-invasive scan. There's no exposure to radiation. But be prepared for an hour to be scanned.
And are these type of procedures, are they covered by insurance?
Most of them are, as long as they're symptomatic. You can get purely cosmetic veins, which are sometimes not covered by insurance, but they don't usually need these invasive procedures. Invasive procedures should not really be done for cosmetic veins, and are usually not required for cosmetic veins. Cosmetic veins can be simply dealt with much cheaper sclerotherapy procedures, because if a significant amount of valve segments are not working, then it's very unlikely you will not have symptoms, and that's what causes you to need a more invasive procedure. Right.
Okay. And what about those little spider type veins? Is kind of do they cause problems, or are they easy to fix?
They're fairly easy to fix in some ways. Spider veins are strange. 40% of all spiders are related to estrogen. Women convert one type of estrogen to another type of estrogen in their body fat, and this other type of estrogen, or estriol, tends to create these little spiders. And that's in about 40% of women. In 60% of these spider veins, there is an underlying problem with the vein valves. The problem is, by looking at them, you can't quite tell. You really have to look at the underlying veins to know, are these spiders coming from below, or are these spiders purely from estrogen? Which is the reason why you'll very rarely see spider veins in men, because men don't usually have that much estrogen, at least they shouldn't. So spider veins can be cosmetic, purely in 40%, or can be because of underlying disease. If they are due to underlying disease, we tend not to treat the spiders. We treat the underlying disease because in over half the patients, the spiders will disappear after that. And if there's a little left behind, then it can be dealt with fairly easily. Now, how do we deal with spiders? There have been two basic techniques for a long time. One is laser, which heats these veins, and one is injection sclerotherapy, which causes them to scar up because of the drug. The problem is if you use too high a dose of laser, you burn the skin on the way in. So we cut down the doses of laser, and that means the veins, spider veins, tend to be undertreated. If we use too high a concentration of the injection, we will close the vein, but we then leave you with staining or with the risk of ulceration of the skin. So we cut down the concentrations of the drug, in which case we tend to undertreat these veins. So the spiders keep coming back. We now have learned to combine the two. We heat the vein with a lower dose of laser and sort of prime it up to receive the drug, and then use a lower concentration of the drug itself. And that both cuts down the risk of having any complications from it cosmetically and gives you an extremely good cosmetic result as well.
Awesome. Okay, well, I think we're running out of time here. Ram, do you want to just give us a quick 20-second summary of the most important points about veins?
The two most important points about veins are, firstly, varicose veins are not cosmetic. Varicose veins will go on to create trouble down the line.
Okay.
Just because they're common doesn't mean they're simple. The second thing to know about varicose veins is that not all varicose veins can be or should be treated the same way. It has to be a horses for courses, and any good center should be able to offer a range of procedures rather than ask everybody to have radio frequency or everybody to have laser, because different veins and different anatomies respond differently to these treatments. So that would be my two key takeaway messages.
Great. So thank you very much. That was really enlightening. I've learned actually quite a lot about varicose veins, Ram. Thanks. And I hope
it also explains why you don't have any spider veins, Mike.
What's that?
It also explains why you don't have any spider veins. You don't have enough estrogen in your system.
Yeah, true. I think I've got varicose veins though. I think I'm developing them. I spend too much time on my feet. But
well, that's a lot to do with height. We now know that the taller you are, the more likely you are to get varicose veins.
Right.
And it's not just the height of the blood column. It appears that the gene cluster that codes for valve development also codes for height. So people over 182 centimeters in height, and you, Mike, are what, 6'4"? So that's almost 190 plus centimeters.
Yeah.
You are a prime candidate for varicose veins, so you're welcome to come in and we will sort you out.
Give me a discount.
You can come free.
All right. Thank you very much, Ram. That was a really good talk. Hope everyone's enjoyed it today. If you enjoyed this video, please share it with your colleagues and friends. Thanks very much.
Thank you.